what I'm trying to say here, like this is very personalized treatment, by the way. Like every patient will have their own drug, right? And I tell the patients if we call it X treatment, it's X and your initials underneath. So this is X and yours. It's not X and someone else can take it. So every drug has the initials of their patients, very personalized. We make for, and that's why it requires, we wish we can treat patients on the go. Like I see a patient today, we have this treatment, let's give it to you. We can't do that. When we see you and you're eligible, first of all, you have to donate some blood to take those T cells from you. And then we have to do genetic editing for your own T cells and, put this chimeric antigen receptor or TCR that targets the cancer cell. And then we infuse them back for you to kill the cancer for you. So this step takes a minimum 3-4 weeks. We're trying to make it better, but that's what it takes. And sometimes during the process of manufacturing, things might fail and you have to redo it again, although that's rare. Most of the times when we do it first time, we're able to do it. But these days we have something called allogeneic. So we have some donors, healthy donors, already donated T cells, and we engineered them the same way. So instead for you donating and waiting for all this, your healthy donors donated T cells that we can take. We already took them and we manufactured them and ready for us. So that's a big advantage for the CAR T cell. We have some of that now on the clinical trials. But for the TILs, if you want to go TILs, there's no way to do that. This is because it has to be your own tumor, right? So we can skip this like over time. So the thing I talked about, it took us over 100 years to get here. As I said, like I summarized it in a few minutes right now. As I said, like the first toxin therapy maybe started around this time in 1800s. That's where, they noticed your immune system is important. But we didn't have enough technology to explore everything I've talked about. It took years and years. The stem cell transplant on the top there around 1957, we said, because we didn't know the specifics, this T cell can do that. We can engineer this T cell. So we said, instead of doing this, let's just replace all the immune system, So that's what the stem cell transplant that we do. We don't look just for one cell. We replace everything for you, and whatever works, let it work, right? So we started doing that in 1957, the first successful one. And there's other immune therapies over time. It wasn't until the checkpoint inhibitors, which are the immunotherapy, which many of you might have received, pembrolizumab and all these. The first approval was and I used to tell the patients that as well, 2011, right? Approved in melanoma. But in thyroid cancer, maybe we didn't use it until a few years ago, right? So that's one thing when I talk about the CAR T cell. When you received immunotherapy, if you received immunotherapy, it's not like you are the first patient received it. Like many patients received it and it's approved and we know what it is, we know how it works. It's just when the thyroid cancer patient received it was maybe 10 years later. This is the way studies work. We can't just open study for everything. We have to know about how it works, the safety, and then move it on. So 2011 was the first checkpoint inhibitors, we call them, or immunotherapy. And then the first CAR T cell was approved. What I talked about, engineering the T cells and treating the cancer. Here I'm talking about commercially available, like FDA, not clinical trials. It was 2017. So we already have it in the clinic for patients without being on clinical trials. We know it works. It did work after many years, decades. We finally have it work. But that was in liquid tumors, blood cancers. When you have the first success, then you start, okay, well, now we know it works, and then things will move fast from that, Same thing with checkpoint immunotherapy, 2011. After that, like many cancers now, we treat them with immunotherapy. So since 2017, all these red things, these are new indications, commercially available CAR T cells. So we are moving fast right now. We started in liquid tumors. That's why all these in liquid tumors right now. In myelomas, leukemias, different targets, for the cancer, different indications. So we have, and this list, it's just expanding those tumors. Okay. I didn't put a slide just for you to know these numbers, but just the one thing important when we talk to our patients as well is everything we do is not 100%, right? There's nothing really 100%. We wish it will be 100% at some point, but that's from one treatment, I don't think would happen. Even when we do allogeneic transplant, stem cell transplant, you can't cure everyone. There are certain things beyond what we can do, but we will keep trying to do that. But these response rates, the first red up row, ORR, it's overall response rate. So you give the patient the treatment, the CAR T cell here, and how many of these patients responded? Their tumor started to shrink, or the cancer cells amount goes down. And these are all same target. So same, called CD19. So we're targeting the same target, just different modalities of doing it. So one of them 52%, one of them 82%, one of them 75%. So over 50% of the patients do respond, up to 80%, which is good. These patients, when we say relapse refractory, this means they failed almost every treatment we know it works. And when they were in those studies, we tell them we have this study, we don't have anything else that we know it works. So although it's not 100%, but these patients, when they get chance to be 50% or 80%, compared to zero, if they were not on this is something great. And many of these patients, indeed, we tell them you get 4 months, 6 months, 3 months to live. We just, so either you do this or you just go enjoy some other days, and you end up like saving a lot of lives by all just doing this. The complete CRR, complete response rate, that's at 12 months, and now we have data up to 5 years. So this is no cancer, not just like responded, like it disappeared. Again, these patients were dying. You got 3 months, 6 months, and then it somewhere between 20, I would say 25 to 30, 34%, 35% of these patients over 2 years, some of them 5 years, from one treatment, engineered T cells given to them, they're still living with no cancer, right? So that's great. There's toxicities here. We'll talk about it later on. Nothing comes without, some side effects, but it works. Emily Whitehead, if you don't know who is she, probably should just Google it. This is the cute little child who probably is, without her being on that study, I won't be talking today to you, right? Because she is the one that advanced the field for us, okay? So she was at the time 6-year-old, 2012, I think. And again, approval was commercially available 2017. I'm talking now 2012. And that's why clinical trials are really important. And the patients who come to enroll in clinical trials, we appreciate them a lot. And I want them also to think that the same way. I mean, even though we don't know, but you may be Emily Whitehead at some point, and you may advance the field with us. So she was actually 6-year-old, and her parents were just struggling to treat her with acute leukemia, which is very aggressive cancer, failed multiple treatments. And her doctors said, you better go home for hospice. But they didn't like the idea, so they just kept, wondering. They went to University of Pennsylvania, thanks for UPenn. They had a study at the time which was about to start. It wasn't even started, right? So it was about to start study about CAR T cell, engineered T cells. And when I talked about the target was CD19, we called it. They said, we have this study, you're gonna wait until it opens and you go in the study. She was lucky enough to open like short time, and she went into the study. That's when she was still under treatment. That's her doctor at UPenn, Dr. Grob. So they said, okay, we have this study. She was phase 1 study, as we know, like we don't know if it will work or not, but we know it's based on the science, it's very, very good. So she went on the study with the CAR T cell, engineered CAR T cell. And a few days after the CAR T cell, she started to be very sick. She had fevers, low blood pressure. The patients who see me, we talk about this. We call them cytokine storm. And she had also low oxygen. She went to the intensive care unit. She was on ventilator from the treatment. It's not an easy treatment. Now we learned a lot. We know how to manage it. because of her. But she was the first, and we didn't know much. Like, okay, she did say, what's going on? We said, like, and the discussion came again. One time before the treatment, they told the patient that go hospice or you do this. Now, after the treatment, they came back to the patient. She's intubated, ventilator. You want to stop everything or, keep going? They kept going, just treat whatever we can treat. A few days later, UPenn guys were struggling what to do, and they started looking at certain blood tests and labs and things like that. There's something called IL-6, interleukin-6. It's a hormone or cytokine in the blood. They found it to be very high when she was intubated and hypotensive and having low oxygen. And then her doctor said, we have something, rheumatology, the arthritis specialists, they use called tocilizumab. It can counteract the IL-6. Let's give it to her, we're not losing. They gave her that drug, tocilizumab, it's called. And just like a miracle, after hours and days, everything started to, this storm, we call cytokine storm, cytokine release storm, start to subside. And, then she was off the ventilator and they did her restaging. She was in remission. And she is now, that's 2022, but now at 24, she's still in remission in the college from that treatment. Right? She was about to die twice, one before the treatment, one during the treatment. So we learned a lot from her. We learned first the cortisol works, and then we learned that we can do something to counteract the cytokine storm. At the time, she had this hypotension, low blood pressure, and low oxygen. We didn't know what to call it as well. Just something, a storm is happening. It looks like infection, like Dr. Cooley, the first slide I put, he was inducing this. He was giving toxins and infections. The patient had fevers and low blood pressure. It looked like that infection. But now we know more 100 years later that there are certain hormones. It's not really infection. It's just the cortisol doing their job and how to counteract this storm. So because of her, and that's the 2017 commercial approval was from this cortisol that she received in 2012. So without her being on that study, we are not here today. Okay, so that's hers. Now, liquid tumors, we have great success so far. We're still working to make it better. But as we know, solid tumors like lung, prostate, thyroid, these are breast and others. These are the cancers that most patients unfortunately die, and we need to do something. And that's why now we're moving. Although I'm a transplanter, but by specialty, I'm also a medical oncologist. I used to treat solid tumors. When I specialized, started doing more transplant and cell therapy for liquid tumors. Now I'm going back to do the same thing for solid tumors, because that's really what we need to do. That's really, we are helping the liquid tumors. We'll keep doing that. But most patients that need help are in the solid tumors. So we're trying to move the same technology that we know it works to the solid tumors. That's where we're in the clinical trials. Since those approvals, we have over 600, now probably over 1,000, what we call cell and gene therapy companies, for a good reason. By the way, immunotherapy before the 2011 was probably dying. We said maybe it's not going to work. Just like a little success makes you revive everything you did for a century. Now, that's why billions of dollars being invested right now to improve this technology. We expect by 2025 to get more and more approvals in liquid and hopefully in solid tumors, which is started to get some in solid tumors now finally. That's just over years. If you look from 2019, 2021, number of studies just increasing remarkably, because we know something good will happen from all these studies. I'm fortunate to work at MD Anderson. We are one of the highest centers that doing those engineered T cells as well right now. Okay, this is just at MD Anderson. One thing in solid tumors, again, it took us a while to know that in liquid tumors is, I don't want to talk about all the challenges, and it's beyond our scope for today, but one thing is, and that's why you may have, even for thyroid cancer, I'm trying to do this now, you may have like more than one study for different targets. It's one thing is we don't know what is the best target. We know that this important, for instance, in thyroid cancer, I'll talk about this, something called ICAM1. We know it's It's very important protein or antigen on the cancer cell. Without it, the cancer cell might die. So that's good. But maybe there's other targets that as important or more important, we don't know. Unless we try in clinical trials, we will not get to know. And sometimes ICAM1 can be the target for this patient, but another target for the other, because tumors are smart. Cancer is smart, can change. It doesn't have to be one thing driving all the cancer. It can be multiple other antigens. So that's what we're talking about here, 30 targets, different studies, different tumors we're trying at MD Anderson. Now we have more than that. I always tell the patients when I see them again that see, it's 42. You're not the first patient being treated with CAR T cell. I want to reassure them. I can't fully reassure them, but it's good to say that you're not the first patient. We have done it. We know what it is. Right now, we treated thousands, over 10,000, 15,000, maybe probably more than that, of CAR T patients received CAR T cells. We know a lot about it. We know a lot of side effects, toxicities, how to manage that. And we learned a lot of lessons. If you were being treated in 2012, we could have told you what we told Emily Whitehead, that something going wrong. We don't know what it is. But now we know what it is. And most patients, I'll show on different slide, we know those intensive care unit rates are all very low right now, like coming down, because we know how to prevent that from happening anyways. So we learned a lot of lessons. Cytokine release syndrome, that's cytokine storm. That's fever, low blood pressure, low oxygen. There's something we call it immune cell associated neurotoxicity, especially in liquid tumors. We have not seen many in solid tumors, but for some reasons from the hormones, from the CAR T cell, they can also cause brain toxicity. Most of it is reversible, but some seizures or confusion, so we know how to manage that now. It used to have very high rates of intensive care unit, ICU admissions. Now it's much less. And there's other things, infections and low counts, because we also give some chemotherapy before we give you the engineered T cells. And the reason we do that, we want your immune system to be a little bit weakened before we reintroduce those engineered ones. HLH, it's kind of, if you want to explain it, like hyperinflammation across many other organs in your body, because those CAR T cells can trigger, stimulate other healthy immune cells in your body to be excited and hyperactivated. Although that may be good in a way that your cancer might eradicate it faster, but they can also cause some organ damage. So a lot of lessons we learned. We know how to manage these things better these days. All right. And one reason we need our patients to be treated at highly skilled center, not any small center treats CAR T cell patients, because it requires a lot of resources. What I talked about is not something simple. And when it comes to toxicities and how to manage them also, it requires a lot of expertise. Some patients end up admitted locally in certain ERs. They have fevers, well, maybe you have infection, they give them antibiotic or Z-Pak. It's not like this. If you have the CAR T cell patient, you have fever, we think completely different. So it has to have a lot of, it's a complex, I would say, we say usually you need a village to manage CAR T cell patients. But once you have the setup, it's easy to manage it. If you don't have the setup, it's very difficult. We need a patient who is fit and active and able to take it and tolerate some of the side effects. A lot of staff education from the nurses to the night floor teams to physicians and mid-levels, treatment, and then oversight. These are some of the drugs we talked about. If you don't have, for instance, tocilizumab, that drug that we gave to Emily Whitehead in your center, don't do CAR T cell, right? Because you need to have the resources, okay? So it's a comprehensive management. This is just a snapshot for MD Anderson. We have a team it has a leadership and different departments and different supportive care departments. It requires a lot of investment. It's expensive, by the way, but insurance covers it. Once on the studies covers it, and on the commercial insurance covers it. We talk about over $500,000 per one treatment. This is what I was talking about. When you have all this in place, then you start, improving your outcomes over years. If you're treated with me in 2020, you have maybe up to 40% chance to be in the intensive care unit at some point. We're not saying you're dying from it, but you'll be sick enough to be in intensive care unit and manage it. Now in 2022, 20% chance. I think now less than 10%. So we know more how to intervene early and prevent this from happening. Okay. Smaller centers might not be there yet, but at least that's what we have right now. And one thing we talk to the patients about, and putting this just very quickly, is because some patients, no matter how you explain it, they still, push back on you. Why I'm doing this? Why I want to stay in the hospital for 1 week? Why I want to stay close to your center for 1 month? Because these are very unique toxicities, and they can happen any minute, any moment. It can happen 3 in the morning. It can happen 3 in the afternoon. You can see me at 9 in the morning, you're doing great. And once I step out, you start having fevers. It just like happen anytime. It's unpredictable. Most of them happens the first 2 weeks, and many of them up to 4 weeks. But after 4 weeks, those side effects go down. So for 4 weeks, you have to be close to that center. If it's MD Anderson, you have to be close to MD Anderson within like 30 minutes or 1 hour. And part of it, you have to be in the hospital for monitoring. So it does require. We have assessment protocols to continue monitoring you and asking you questions, even though you're feeling good. This is grading. We can skip this one. This is very important here because many patients, they will sometimes think it's silly, but it's not. This is kind of how we capture early toxicity for your brain before it becomes severe. Again, 10 years ago, we didn't do that. And we waited until the patients are just out of it. So now we have to, every time the physician step or the nurses, they will ask you, what's this? You have to mention this is a phone. If you make a joke about it, say it's a pen, you score less, When I started doing this years ago, there was a question about who is the president of the United States, but that created a lot of political challenges. This is a real story. Then they changed it, Someone said like Jim Carter, are you sure? So we took that question out, but we kept those questions now. And one of them count backwards and right-handing. Like you have to write statement every day. For instance, this is just an example of a patient who, I love Shawnee. This is a real patient, right? Statement every day, fighting the cancer, but at least want to make sure it's safe, especially it's not causing other problems in your heart, in your lungs. And then the plan was to treat up to 24 participants on this study. You have to have either or fully differentiated to be treated. And this is very important. We talk about ECOG status, functional status. I mean, to be active is extremely important. The number one thing I talk to the patients about on treatment, even not just before treatment, it's stay active. We know cancer makes you weak. We know treatments makes you weak, but the only way to fight that is to stay active, motivated. There's no other way. There's 2 things, studies done, we have studies done about this. 2 things help you, what we call cancer-related fatigue. It's exercise and stress management. Being a cancer patient, you're under stress always. But you have to find ways to enjoy your time, have some fun, and then exercise. These are the only 2 ways. If you don't do them, you just get worse and worse every day. So very important to be functional. If you come to me in a wheelchair, I won't be able to treat you. It's just like, it's not me deciding. It's just the FDA after me and everybody after, and it's not safe. You will die from the treatment. I told you there's a lot of problems before you get the benefit. So if you're sick, you can't get the treatment. You will die before you get the benefit, right? If you're not active. Study. Yeah, the pen, they have different target. Yeah. But this is more advanced at this point. We treated more patients. Design when we screen patients after we know that you have slot for you, the apheresis, know what to manufacture your cells, and you get some chemotherapy for 3 days, and then you get the CAR T cell, and then we have to watch you at least for 4 weeks at MD Anderson, 1 week in the hospital, 1 week to 10 days in the hospital, and the other you have to stay. And then we watch you over time. This study, as I said, it's a little bit more advanced. So we already treated patients at a very low dose, which is 10 million cells, and we went to higher doses at 100 millions. Then we went to 500 millions. Tried also 750 millions, but we found out the 500 millions is the best dose. So that we're very advanced on this study to the point that we know what dose is the best at this point, and this is the dose that we're using moving forward to treat any patients, and we're looking to do a phase 2 soon on this dose. We presented some data, so I can't disclose what's not disclosed here. So I just want to disclose here the ones that we already published. The first 3 patients were treated at Cornell at the time this study opened there, and thanks for the Cornell. By the way, the ICAM1, the concept, the science all came from Cornell. So thank you for Cornell for doing this and the scientists at Cornell. So they started this, the first 3 patients, 10 million cells is a very low cell, but we have to start like this. And thanks for these patients who went into 10 millions knowing may not benefit. But at least we were able to like a lot of this patient has a lot of disease. As you see, all these black dots are cancer. But we were able to see some infiltration of the CAR T cells. So CAR T cell seems went to the tumor, although the tumor did not shrink much. So that was a good first kind of proof of concept that this CAR T cell works. And then lately, like in ASCO, which is a few months ago, we presented an updated data. And this is public. If you Google it, you can find it. We treated at that point, we infused 10 patients, not just 3 patients, up to age 65. 6 of them have anaplastic thyroid cancer, and 4 have poorly differentiated. Most of them received multiple lines of therapies. And the good thing is we didn't find any detrimental, side effects on these patients. This is the first 10. We treated a couple more after that, but not counted here. This is the CRS that I talked about, cytokine release syndrome that Emily Whitehead had, low blood pressure, but it was all grade 1 or 2. Okay, so that's something good. What she had was grade 4, basically. She was like, intubated in breathing machine. And many of these patients received the tocilizumab, right? So before they get to that's grade 3 and 4. So that's one of the advancements that we have done. We didn't see anyone with neurotoxicity, which is really, it's relatively common in liquid tumors. Okay, so that's good. When we say phase 1, it's always, I know patients and myself, everyone wants to see responses, but when we do them, we're not doing them to see responses. We're doing them to make sure it's safe, and then we move on to see the responses after that, right? So it may be patient number 10, number 15, number 20 gives us the idea that this is working, let's keep going. So we just have to keep trying. And when you look at the responses from these patients, again, those patients treated, some of them 10 million, some of them 100, some of them 500 million. So we know now 500 million is the good dose. But if you take all these patients, there was 22% of these patients, their tumor did shrink. If you look at just the dose level 2 and 3, just eliminate dose level 1 because we know it doesn't work, it's just safe. Then 67% of the patients, they did have benefit. Either shrinkage, even though I have patients like for 7 months, 8 months, the tumor did not disappear, but they didn't get any other treatment after that. Just like we call them disease control. But there's 33%, so 1 out of 3, they did have objective response, and some of them remission as well. This is one of the patients. She had anaplastic thyroid cancer, 68-year-old. And then if you look at the right side on the tumor, this is the baseline, the cancer in the lung, just as an example. A good thing about this study, when we do it, you'll have multiple CAT scans. It's very, very good CAR T cell technology. You do 2 different PET scans. One PET scan to look at the cancer, but there's another PET scan called DOTA-TATE. We engineered the CAR T cell in a way we can picture them, we can see them on the PET scan. We can see the CAR T cell infiltrating the tumor. Okay, so that's why there's FDG and DOTA-TATE. Both are PET scan, but just different. You take different dye, when they do the CAT scan. So when you see here, for instance, DOTA-TATE, all this activity, this means the CAR T cell just infiltrating the tumor, because it wasn't like this at the beginning. So this patient over time, after week 6, starts shrinking the tumor, and we call this partial response. That's another patient, 58-year-old. He has BTDC with anaplastic. You look at the cancer at the top there, and then over time, how it disappeared completely. That patient went into remission for several months. So this is another patient that those black dots, you can see those are like the cancer, for instance, like here. And then after treatment, they disappear. So we know it works, and we know it's safe. Now we're just on the stage to, and I go back to the liquid tumors. Not everyone will benefit. It's very unfortunate, but unless you try it, you might be that one, but we don't know. We're hoping at some point we can help every patient, okay? This is just looking at the blood CAR T cells, just again, proof of concept for us. Those lines like this mean the CAR T cell are in your blood and then going up and down and going to treat the cancer. I'll finish because we're over time. We think immunotherapy has, when I say immunotherapy here, all these, 1 century that I showed you, it really has revolutionized our landscape of treatment, especially from 2011, like the immunotherapy that moved on. Cellular therapy, I believe that's what now, after the Pembro and the checkpoint inhibitors, I think they did a great job the last decade. In this decade, the cellular therapy, probably that's where we will be treating most of the cancer, or hopefully curing. I mean, I do treat cancer to cure them. I'm hoping to cure them, not just to give them, some responses. We just have a lot of challenges still. That's why we need more clinical trials, and we appreciate the patients to be on these clinical trials. It's double benefit. Hopefully you achieve some response, and you'll be enjoying some good quality of life from being in remission or even controlled disease for many months from one infusion, but also helps us understand more and helping more patients, being part of these studies. This is, you can do www.letschatcarT.com. So it's very good website for the patients, explains how the CAR T cell in simple things, simple language. I went through it yesterday and looked different. It's really good. What's CAR T cell, what to expect, what to do this, what to collect, so we can go through this and understand more about it. Thyroid, we talked about this. I don't want to repeat again, but the good thing is because we think it's working right now, we plan to move to a phase 2 registration, and meaning making it hopefully available for other patients, even outside the clinical trials. But the study, until we get to that point, is still ongoing at MD Anderson, City of Hope, Northwestern Chicago. Cornell is part of the study, but I don't think they're accruing right now, and we're planning to expand, hopefully in the future, to other centers. Thank you all, our patients and the wonderful family. This treatment cannot happen without caregivers, So the caregivers are essential. Part of this treatment are really essential. If you come to me, you don't have caregiver, you don't get the treatment, period. And they do a great job. So it's part of the success of the therapy to having a good caregiver. So that's why we thank them all the time for being good caregivers. Okay, take any questions.